realize where that pouch is. I mean, this is so curable if you wanted to, but you have to fight the urge to cure it in the first go. Here's it from the PCA as well, the same point, everything's coming to one point. So overall, clinical outcomes are not great. These are things that have not improved more because this was Losunia's paper in 2006. Texas Children's, while Peter Kahn was there, my predecessor, they put it out in 2018. Outcomes were more or less the same. I recently submitted our data to a pooled analysis, and there's some interesting trends there, but nothing game-changing over there. Ultimately, patient selection is really important. Staged embolization transarterial is safer in neonates. Slowing the AV shunting to get to normal conditions is important. Avoid EVDs, and multidisciplinary is extremely important. Some cool things happening on in utero, which we can maybe chat about later, but nothing game-changing quite yet, but definitely a cool approach to doing this, and we're really invested in that as well. And it's a huge team effort from all these people, and we're lucky to have really good pediatric neurosurgeons. I don't do the pediatric neurosurgery part, I'm just doing the interventional part. And we really put all these things together. We now are going for a yearly pediatric neuro-IR workshop geared towards fellows and early career people. We had one last year and this year as well, and it's so far been a great success with the help of some colleagues down there. So yeah, I'll wrap that up over there. A lot more to talk about, but for a 15-minute, I think this is hopefully serves as an overview.
Thank you very much, Omar. That was fantastic. So I heard recently that Darren Orbach did an in utero made of Galen, the Galen case. So can you talk a little bit about how, what's the aspiration for that? What are they trying to do in that particular case? Because, otherwise, as you pointed out, since La Junias, we're still doing essentially the same thing, only slightly different techniques.
So in utero, the thought is, and we've talked to their group about this as well, the thought is that what we can't do ex utero, which is just cure the fistula, put a lot of things in the pouch, the malformation, perhaps it's more tolerated in utero. The other thing we don't end up seeing or getting consulted on necessarily is the vein of Galen cases that were so bad that they pretty much die on birth, or their heart failure is just so bad they're not even going to call us for it. So the thought is maybe you can find the ones that are actually so bad that they're going to pretty much, die after birth or very shortly after, and slow down the fistula. And the approach they're using is a percutaneous ultrasound guided, finding pretty much the soft spot that gets you into that accessory torcula, that dilated part. Once you've punctured that, feed a catheter in or just coil straight into the pouch, and then hopefully that slows it down. Maybe it just turns it off completely, but since they're in utero and there's a lot of reversible flow through the umbilical vein, they can tolerate that venous shutdown much quickly. Or they'll make it so that their heart isn't congested, and they'll make it to actually get transarterial.
So why would they incur the risk of venous takedown as compared to post-nate?
I think either there's maybe it's just atmospheric, but I think it's the reversal. It's the fact that they don't require the extreme dependence on, I don't know if it's actually because there's an assistance from the umbilical outflow, pressure changes. Maybe it's still early enough that other veins that we're going to take over can still be salvaged. There must be something, and this is just theory. I don't know if it's actually going to be true. Maybe it's going to be just as devastating. I know a bunch of cases have not had good outcomes. One did. And so I think it still remains to be seen if it's going to be something worth pursuing.
But how you control the movement of the fetus when you are doing it in utero?
Yeah, you don't. You need the assistance of, and we haven't done this procedure yet. We are doing a different model in sheep that actually involve puncturing the heart. So it's transcardiac instead of actually doing that.
Okay.
It's still going to have a lot of problems because they're there. But you actually can stabilize things with the help of the OB-GYN surgeons. This is now, we're talking about fetal surgery. You know how they're repairing spina bifida in utero, they're repairing a lot of other things now in utero. So they've gotten good enough that they've got tools to help assist. But a lot of the techniques they just had is just manual, sort of holding things and using an ultrasound. And it's a big enough target that they can kind of get the needle into it.
Okay.
Thank you. So you described two techniques for the treatment, the W and balloon use of the W and balloon catheter and the coiling, then to reduce the flow and onyx injection. But do you use also glue for this kind of malformation? Because when we use a high concentrated glue, we can also treat the fistula.
Yeah, absolutely. So with the Scepter mini balloon, glue can sometimes pop it.
Without septal balloon, with a simple microcatheter and just 8% glue.
One of the approach, and again, it's dealer's choice. It's whatever you feel comfortable with. I agree. Extremely thick or higher concentration of glue will polymerize extremely quickly as well. And some of the things that I kind of look at, it also depends on how big the feeding artery is and that you're in. Some of the ones I showed you with the balloon inflated, it's almost 2 to 3 millimeters and the catheter smaller. But if you're in a smaller vessel and you're wedged, that's perfect for a very high concentration NDCA. But ultimately, if you're kind of flapping in the breeze, you're in a large artery that just happens to go in maybe the mural type, even then, I know a lot of people really prefer very concentrated kind of glue for that. As soon as it comes out, it polymerizes. I think it's fine. Whatever. It definitely does assist. It does help once you can slow the flow down. Then it's a little bit more controlled.
Very good presentation, Dr. Omar. I've got two questions. One on MRI, established encapsulation changes. Does it change your treatment modality? Would you still go for treating those childs who have encapsulation changes on MRI?
You mean the melting brain?
Yeah, established.
Yeah, so it depends. The thing that's still like we hang our hat on is the Basitre score. So if they do have that, they're probably going to lose a lot of points in the neural column. They'll have subclinical seizures that loses points. They'll have other things or status or other things. So yes, you will lose a lot. But if they're still cardiac, renal, and respiratory are still decent points, they'll actually be above 8. And again, the score isn't perfect, but it is helpful to give you some guidance about how and so one system can be trashed, but if the other one is actually keeping the points up, it's definitely worth going. Even if the MRI shows that there's a lot of sort of RDT2 changes, encephalomalacia, there still could be that. Now, one thing I quickly went over is the outcomes are still not great. They had a very politically incorrect category of moderate retardation and this and that. And the majority of them on neonate actually have significant cognitive effects. And obviously that's probably from some of those brain changes.
And one more thing, when you are planning a staged embolization in this vena malformation patients, what's your how many feeders you try to take down in one session, and what's the when do you do the second session? What's the difference?
Yeah, great question. So how many feeders to take down, it should be the maximum you can take until you're really running your contrast dose, because it's just every puncture is so high risk. And typically what seems to work for us is if they require neonatal embolization, it's neonate, and if that helps and they can get weaned off of their ventilator and off the diuretic drip, and they're gonna make it, they're tolerating PO and they're gonna go home, the next one should be at 5 to 7 months. And then after that, 3 years is usually what it is. Once they get into the later stages, you can be a little bit more aggressive. And I mean, Dr. Berenstein, who's really kind of has this amazing experience, he's shown cases with 16 to 20 embolizations and not ultimately cured till they're in their teenage years. And that's kind of typical. But for the neonate, it seems like neonate, 7 months, 3 years, as long as the heart's tolerated.
Thanks, Omar. I've really enjoyed coming to your workshop last year. That was a great time. So I'm curious about this concept of not shutting it down too quickly. And in my mind, like I've always thought about it in terms of you don't want to induce this like overshooting thrombosis in the vein, and then it kind of takes over the whole system as you alluded to. Have you ever seen that? And if you do encounter it, do you guys heparinize or?
Yeah, I mean, so we really encountered more in dural fistulas as well, and that experience kind of comes from even spinal dural fistulas that show. One thing about when I do my spinal dural fistulas surgically, the one thing I wish I could do is heparinize them, right? But you can't because you got them open. But what I always do for endovascular cure fistulas, I heparinize them post-op. And so that concept's the same. To be honest, we haven't had a vein of Galen while I've been there for the last 3 years now where we were so aggressive that we shut the whole thing down. There has been things like that that were a little bit more peel fistulas that we shut down and we're kind of worried. We heparinize for the first day or two and then we keep them on aspirin. That's usually been enough. But if that were to happen here on the vein of Galen, we probably would also do that, be very aggressive with that, make sure that they're heparinized.
Thank you very much. That's the end of the session.
Thank you, Dr. Tanveer. Are there any comments from